Good morning from sunny Miami. This is Dr. John Bennett for the Neurosurgical TV channel. We have another in the conferences or presentations for the Neurotrauma Conference. We're talking about various areas of neurotrauma, and we're presenting it in a hangout format. Today we have the pleasure of having Slaven Gojkovic. He's a medical student superstar from Croatia. We're also joined by a couple of panel members. We'll introduce them first. Hello, Rakesh.
Hello, hi. I'm Dr. Rakesh.
Okay, you're doing a neurosurgical residency in India, correct, Rakesh?
Yeah, I'm doing a neurosurgical residency in India. And I'm very glad to be a part of this Roton course by Dr. Slaven from Croatia. And great to have Simon and Dr. Bennett. Thank you.
Well, welcome, Rakesh. And Simon.
Hi, thank you. Always a pleasure to join Slaven's presentations because I learned so much. So I'm looking forward to this. Thank you.
Very good. Welcome, Simon. And okay, Slaven, it's all yours.
Okay, thank you very much, Dr. Bennett. And I'm also very glad to be part of this great conference, another conference of the global size. I had the honor to be invited here to present to you about the approaches to the brainstem. So this presentation will be, in fact, also part of the Roton course. This is the course which I started here at the University of Zagreb Medical School, which tries to involve medical students into thinking about the neurosurgical microanatomy. And we are trying to do this through the great collection of Professor Roton. So I'm currently now at the Croatian Institute for Brain Research, which is the institution of my medical school, which allows us as the students who are interested in these fields to give our presentations and to promote our knowledge. So I'm very glad and thankful that I can present it from here to you, and also to the Neurosurgical TV for inviting me here. So what I wanted to say is that this presentation will in fact be a repetition of all the presentations that I've done thus far for the Roton course, which are all preserved on the YouTube as part of the Neurosurgical TV. So this is just another presentation of the Roton course that will kind of bind up and all together the presentations that I was talking about before. So today we will focus more on posterior fossa, and we will try to integrate all the knowledge that we gained about the posterior fossa approaches. So if you missed some of the earlier presentations, some of the contact points with them will also be take part today, and I will try to do this in the most concise and understandable manner. And I also would like to invite all the panel members to participate and to give their thoughts while I'm presenting. You can stop me at any time, and I would like to make this a bit of a discussion. So if you have anything to say or any thoughts, you can share them as you wish. Okay, so we can start. This is actually the fourth presentation during the Roton course. So for now I did the presentation on the Cavazzi approach. That was the first one. This is one of the approaches that can be done to the posterior cranial fossa and to the brainstem. Then there was the presentation on the far lateral approach. I will talk about this also today. And the presentation on the Thiele-Wheeler approach, which we did the last time. So this is the presentation that will bind up all the approaches that can be made to approach the brainstem. Okay, and I just have one of my colleagues needing me something here, so I'm presenting live here also. So just a second, I will. Okay, hello. Okay, so you can sit if you have time. Okay. All right. I'm very sorry for this distraction. Okay. So bye. All right. So as I was saying, this is the fourth presentation that will try to bind up all these approaches. So we can start. So the problem we are dealing with today is this structure. Okay, so this is the brainstem. If you see it, it's kind of. I put this slide because it shows very nicely where the brainstem is positioned in the head, and also how relatively unapproachable this area is, because you have it right in the midline. Okay, so you have all these structures in front of it, all these structures on the back of it, all these structures on the top of it, and all these structures over here. So this is, if you view it in the 3D, you have it surrounded, completely surrounded from all sides. So it's relatively unapproachable, and some areas of the brainstem are very, very hard to approach even today, like this area here, where the basilar artery lies in the clivus. So this is another picture which shows you this in the transverse section. So this is just the view of the posterior fossa with its components. This is the cerebellum, the largest structure, as I was talking the last time. This is the tentorium cerebelli, which covers the tentorial surface of the cerebellum and divides the infratentorial space, which is positioned below the tentorium, and the supratentorial space, which is positioned above the tentorium. Okay, so you should always try to think about the approaches as well as being either infratentorial below the structure or supratentorial above the structure. Okay, so we have to distinguish between these two spaces. And the brainstem is positioned right here, so it's also completely in the midline, if we try to understand it. So it's very hard to be approached as well. Then this is just the MRI scan, which also shows you this in a radiological manner. Okay. And now also another section just to show you the coronal section shows. So again, brainstem is relatively unapproachable and positioned in the midline. Right. So if we are trying to think about this structure, which I just showed, the brainstem, we have to ask a question: how do we approach this structure? So if it's positioned in the midline, and if you can't, if it's surrounded by everything, how can you approach it? I don't want to make it seem like this is an easy thing to be approached. There are ways today, but posterior cranial surgery, posterior cranial fossa surgery is considered one of the most complicated even today. This is because of the neurovascular structures. And because of this, you will see that there are some ways, but these ways are also always modified, so they might not be perfect. So you always have to combine few approaches and to think in the associative manner when you are trying to approach some lesions in the posterior fossa. And this is like a general rule in neurosurgery, as it seems to me. Okay, so this is just a review of these approaches. Approaches to the brainstem can be anterior. I will just count them down like this for the first part, and then we will go through each one of these in a little bit more detail. Not every one of these approaches will be reviewed today because this would take too long time. But I will review just the ones that we already been through the presentation I've made this far. So we will go through the other approaches in the future, trying to understand the anatomy of every section, and then we will try to bind it all up together on a clinical case. Okay, so from the anterior we have subtemporal approach, which can be seen here, retrosigmoid approach, which is the workhorse of the posterior fossa, as Professor Roten calls it. So it gives you the approach to all the cranial nerves, as you will see later. Then the anterior petrosectomy. This is the Cavazzi approach I was talking about in my first presentation. Then the translab approach, also the transcochlear approach, which can be made here, but both of these approaches, both translab and transcochlear, can be not indicated because you can lose hearing in the patient. So these approaches are only used when there is no chance of preserving the hearing in the patient. Then the far lateral approach, which brings you here to this lateral side of the brainstem, the transcavernous approach here, and finally the endoscopic approaches, which kind of can bring you to this whole middle area of the brainstem. So as you can see on this slide, there are various ways in which you can approach some structures, but not all these approaches are sufficient to get you everywhere. So you always have to think about combining a few approaches and how can you approach the exact part that you need to approach. So this is all microsurgery, and these are all small areas, and because of this you have to perform a craniotomy wide enough to get you right exactly where you need to be. And this should always be kept in mind. Okay, then if we look at this at the posterior part of the brainstem, we also have the retrosigmoid approach, which is, as I stated, the workhorse of the posterior fossa and posterior fossa cranial nerve surgery. So this is one of the most often used approaches. Okay, and then if you have a lesion that is perhaps going through the tentorium and that is making a communication between the infratentorial space, which is here, and the supratentorial space, which is above the tentorium, you can always think of the supratentorial approach, infratentorial, or combined supra-infratentorial approach. So these approaches all can be done. It is usually better not to open the tentorium when you try to operate in this area. But if you cannot save it, preserve it, then you should consider doing a combined supra-infratentorial approach, or as I stated, the transtentorial approach. This transtentorial approach can be used because venous complexes in the tentorium are not such high number, and it is usually safe to do a transtentorial approach if this is needed to be done. I can remember that Dr. Gadol reported a patient of his that had a lesion in the posterior fossa which just rose above the tentorium. So there was part of the tumor, I'm sorry, it was positioned supratentorial, yes, but he was going through an infratentorial approach. So there was part of the tumor infratentorially and the main mass of the tumor supratentorial. So when they did this operation, they kind of opened this small part of the tentorium right adjacent to the brainstem, and they pulled the tumor infratentorially, and in this way they moved it out. So they didn't actually open the tentorium. This is very interesting way in which these surgeries can be done. So I'm just mentioning this to show you how it is never simple when these kinds of surgeries are performed. Okay, then one of the approaches which I was talking about the last time, this is the Thiele-Wheeler approach, which brings you to the rhomboid fossa, which is the bottom or the floor of the fourth ventricle. Okay, so it brings you to this most posterior part of the brainstem when you have access through the cerebellum. Okay, so this is the Thiele-Wheeler approach. And now, when we considered all the approaches, we will, as I said, we will go in more detail very soon. We should now think about how can you even enter the inside of the skull. So every neurosurgical procedure is consisting of a craniotomy. Almost every neurosurgical procedure, at least the ones that are taking place in the intracranial space. So now, when we talked about in which ways you can enter the box, now we have to move backwards and think how can you even enter the box? Which are the means in which you are opening the skull? So I just wanted to show you some of the craniotomies that are usually used for this. Okay, and I will have to close the PowerPoint now and go on YouTube to show you some of the videos. I hope everything is right with my sound and presentation so far. Okay. So as I mentioned, there was this first approach. This is the subtemporal approach. This subtemporal approach is important because it can also bring you to the lateral side of the brainstem. This subtemporal craniotomy, which is performed right here on the temporal part of the skull, on the squama of the temporal bone. I'm sorry, Simon, I'm hearing some sounds here. Is everything okay?
That's just a ping in John.
All right, okay. I just wanted to ask. Okay, so this is the picture that is showing you this. So if you want to perform a Cavazzi approach, and this Cavazzi approach, as I mentioned in my previous lecture, is the approach that is usually performed when you have a lesion at the CP angle, so the cerebellopontine angle, and you don't want to lose the hearing in your patient. So this approach is very interesting because it can preserve the hearing, because it is going through the anterior part of the petrous bone. So this approach is also called the anterior petrosectomy approach, or Cavazzi approach. I will show this in more detail later, but for now, you should just remember that this is the subtemporal craniotomy. So it is done on the lower part of the squama of the temporal bone, above the ear. This is the incision line, which is placed. And now we can see here how it was made. It's usually made just marked on here on the head of the patient. Okay, so this is a cadaveric dissection. I don't know if the craniotomy is exactly performed, but I just wanted to show you where the incision is placed. Then another very important craniotomy is this. Okay, so this is a craniotomy that is performed for tumor in the fourth ventricle, as the picture before this showed. And we are now looking at the occipital bone here. And this is the craniotome, an instrument that is making, that is cutting the skull and making a circular opening of the bone. Okay, that will bring us to this posterior part. So this is the midline over here, and this is the occipital bone. So in this approach, the surgeon is drilling the lower part of the squama of the occipital bone, which will bring him to the posterior part. So craniotomy is usually done with burr holes placed. These are the burr holes. And then the craniotome is used to connect the burr holes. You can sometimes also use one burr hole or more burr holes to perform this craniotomy. Okay, so we can see all the structures. This is inferior, this is superior. This screen is magnified because the surgeon, this is a view through the surgical microscope. So right now, this is the dissection being carried out. And in this approach, if the pathology is going to the inferior part of the neck, you can also dissect the posterior arch of the atlas, and this can expand your approach and give you access to the posterior part of the neck, which can be very useful, which we might be seeing in this video as well. So this is Dr. Pagzaban, who is Washington, micro neurosurgeon in Washington, and he's posting lots of great videos like this on YouTube. I'll just speed this up a bit. Yes?
I wonder if I could interrupt you with a question.
Yes, of course, Simon. Yeah.
I was wondering, in Croatia, would a typical neurosurgery residency allow you to go through all of the approaches to the brainstem? Would they all be covered within a residency? Is that typical of a residency?
Well, it should be. I think it is. I'm sorry, I'm hearing my voice now louder. Okay, it's okay now. It is typical because every neurosurgical residence is standardized today, and in Croatia it is done much the same way as in any other country. It is the time that it takes to become a neurosurgeon in Croatia is 6 years of training after the medical school. And it is usually divided in a few areas. So you first have some training in general surgery, which is the combined stem, surgical stem as they call it, and so you gain some basic surgical techniques. And this is more like small surgical procedures that are done in like family medicine, and then you progress with your knowledge in neuroanatomy, and you with this progression you learn all the approaches and even some of the more complex approaches. I don't think that some of the very complex approaches, such as the Cavazzi approaches, are exactly taught in detail during the residency, except perhaps in the last years of residency. So these approaches are usually reserved for senior residents or the ones who are in their 6th year here in Croatia of residency. But usually it is all covered, and as I saw, some people who are waiting for their specialist exam after the residency. In Croatia, they were already very skilled neurosurgeons, so you could not really tell that there is a difference. They were such flawless in technique, in their understanding of this. They were complete neurosurgeons. So I think that this program is very well, and it is very nicely covered in this basic neuroscience. Because, as I said, I'm right now at the Croatian Institute for Brain Research, which has one of the greatest banks of embryonic tissue and of brains as well. I think in the world. So this is really a rare place we have here in Croatia. And Professor Kostovic is the one that took great part in discovery of the subplate zone during the development. This is the zone where temporarily neurons are growing during the development of the cortex on their way to the upper portions of the cortex, so more superficial. So this was a human-specific layer that was very interesting. And we have here our craniotomy done. I'll just go back a second and I'll describe you 2 crucial points. Okay, so as you saw, this was just the bone being removed, and now the surgeon is elevating the bone flap that he made. Okay, so he just detached the dura underneath the bone, and he is now elevating this bone flap. I think this will be an osteoplastic craniotomy, so you can divide craniotomies into osteoplastic or osteoclastic. Osteoplastic are preserving the bone, which means that after the surgery you are usually putting the bone flap into its place and fixing it with plates and screws. And in osteoclastic craniotomy, you are usually removing the bone completely. This can be even done with a rongeur, and then place a substitute for the bone. And this is usually this is a thing used in plastic surgery usually, and this is the metaacrylate, which is a substance that you can shape, and then it hardens in a matter of minutes or even seconds, and it resembles the bone of the posterior fossa. Okay, and this is just, as I mentioned, the cutting of the C1 arch, posterior arch of the C1. Right? And finally, when this is done, you have a nice clean access to the fourth ventricle. So this is the tumor. These are the tonsils of the cerebellum, the posterior surface of the cerebellum. This is the vermis here. Okay, so this is inferior again, this is superior, and lateral sides. Okay, right, left. And now the surgery is carried out, and the surgeon can easily remove this tumor, which is most probably to medulloblastoma or something like that, because it seems to be arising from the vermis. Or it may be, I think it was stated that this is an subependymoma, actually, but this is the usual position of this tumor. And after the transection, the tumor is removed. Okay, and another craniotomy which is very important. All right, so this is the positioning of the patient for the retrosigmoid craniotomy. So as I stated, retrosigmoid approach is the workhorse of the posterior fossa because it brings you to the CP angle, which is actually in the front lateral side of the brainstem. But this approach is interesting because it brings you from the back. So this is the occipital part of the head, and it brings you from the back to the anterolateral side of the brainstem. And it is very curious how can this be done. We will go into more detail after this when we will review the anatomy required for these approaches. But for now, let's just examine the craniotomy. So one burr hole is placed inferior to the sigmoid sinus. So this cannot be very clearly seen here, but you have a sigmoid sinus going like this here, and burr hole should be placed right here. So this is the sigmoid, this is the transverse. And usually the burr hole is placed right at the division point of the transverse and sigmoid sinus here. And then you can perform larger craniotomy down here and have access to the CP angle. To access the CP angle, once you've done the craniotomy, you can you need to retract the cerebellar hemisphere. And this can be, so we see here the opening of the dura. Craniotomy has been carried out, so we don't have the bone here, it has been removed. Now the dural stitches are placed, so the dura is opened. And finally, we will see the elevation of the cerebellar hemisphere. So it can be either moved with the spatula downwards, upwards, or medial. And based on this position of the spatula, you have different approaches to your angle. So like that. This is just placed to preserve the surface of the cerebellum, and now the spatula will be introduced. Okay. I will try to fast forward this a bit because, as you will see, we have still lots of considerations to do in front of us. Okay. So now I will go back to the presentation. Right. So I just stated some of the craniotomies here, and now to the tricky part. This is the intracranial part of the procedure. So we now examine just how to enter the box or the skull, and now we have to consider how to find your way while you are in the skull. So while you are in the intracranial space or the infratentorial space, which will mostly be considered today. So this is the anatomy, which is the most complicated, but also the most beautiful part of brain surgery. Okay, so as I said, we will just review these approaches again because I really want you to understand this is not complicated, and this can really give you a certain amount of understanding and realization when you are entering the neurosurgical operating room. So this is the skull-based view from above. Okay, so we have this is a cadaveric specimen, and we can see the dura lining this space. So this is the fossa that is interesting us today. This is the posterior fossa, the middle fossa right here, and the anterior fossa here. Okay, so we will now see so we just watched how can you enter this posterior fossa. This is the suboccipital approach going through the midline, through craniotomy here. This is the retrosigmoid approach. Okay, far lateral approach over here. And just to help you with this, we will now go stepwise through this. So this is the transclival approach. This is the first approach that brings you to the anterior surface of the brainstem. So brainstem is positioned here, as you can recall from the slide I previously showed. Okay, so it brings you through the clivus, which is a bone that is gradually going upwards here on the skull base, and which connects the middle fossa and posterior fossa. Okay, so these approaches are very interesting, and they can be done through the mouth and through the nose. Approaches through the nose are most usually used today, as I will show you later. But mouth is also very anatomically convenient way to approach this, at least theoretically. But these approaches are not usually done today. Usual approach that is done today, which goes through through the sinus here, is the endonasal endoscopic approach. So it's going through the nose. Okay, but mouth can bring you through the clivus. Okay. Then the anterior petrosal middle fossa approach, this is the Cavazzi approach I was talking about. So it goes through the petrous bone right here in front of the cochlea, which is here, and the semicircular canals, which are here. So it brings you right here behind and below the trigeminal nerve, which usually sits here, into the posterior fossa, into the CP angle. Then the posterior petrosal transtemporal retrosigmoid approaches. These approaches are going stepwisely over here, so they can go through various parts of the temporal bone or the squama of the temporal bone. So here we have the translabyrinthian approach, transcochlear approach, then the transtemporal approach, which is usually going through the squama of the temporal bone, and retrosigmoid approach, which we saw right before this. So it is done through a craniotomy placed here. Okay, so on the squama of the occipital bone, just below the branching point of the transverse sinus, which is here, and the sigmoid sinus, which courses around here, okay, around the condyle. And finally, far lateral transcondylar approach. This is an approach that is carried out to the condyle, but does not go through the condyle, because this is then extended far lateral approach, which is called transcondylar approach. So usually it is done exactly to the point of the condyle, but not through the condyle. I stated before in one of my talks that if you make this approach through the condyle, you can sometimes endanger the craniovertebral junction stability, and this is the reason why it's usually the surgeons are trying to preserve these structures, the condyle. Condyles are positioned here. Okay. So on the lower part of the skull base. And finally, the midline approach. This is the suboccipital approach, which I mentioned before. Okay, so now we will go stepwise to these approaches and try to review them. So first we have all of them together again. So this is the transcavernous approach, which brings you through the cavernous sinus, which is in front of here. Okay, so imagine that you are looking at the anterior part of the head, just like you are looking at me. And if you put a speculum in one of in your nose, then you can see the posterior part. Okay, here. So this is the clivus, or see, this is the sphenoid bone already. Ethmoid bone, then sphenoid bone. So through this, you can perform an endoscopic approach that brings you right here to the interpeduncular fossa. And this is actually a supratentorial part of the brainstem, but it can be approached, and it is usually approached through these endonasal approaches. And today, these approaches are also commonly used in surgery of the pituitary gland. Okay, so then here we have the translab approach. Cavazzi approach, the anterior petrosectomy approach, as I mentioned. So this is the approach that is very interesting because it brings you here to the boundary of the trigeminal nerve. We have 7 and 8 here in view, also almost to the foramen of Luschka, and third nerve here. Okay, so finally, you can extend some of these approaches to give access further. Also, other approaches to this part, and what is interesting is retrosigmoid approach, as I mentioned before, which brings you over here to the line of the cranial nerves. So we have here 5, 7 and 8, 9, 10, 11, 12 here. And this is the flocculus, which covers the entrance to the transverse part of the fourth ventricle. Okay, so this is the CP angle. Okay, then the posterior approaches supra and infratutorial, as I stated, and also the transtentorial approach, which can be used, or you can combine the two approaches. Okay, then the tilovelar approach, which brings you to the fourth ventricle. This was done before through the vermis. So the vermis has been split usually in these surgeries, vermis of the cerebellum. But today, when there was an observation that some patients, usually the younger ones, develop transient cerebellar mutism, this approach has not been used commonly since then. So the surgeons were trying to find new variants of approaching the fourth ventricle without hurting the cerebellum and causing the mutism. So what they came up with was the tilovelar approach, and this is today's topic. I will go through these approaches in more detail very soon, but it can bring you to this area. So this is the rhomboid fossa, and it is using the natural anatomic pathways which are not hurting the neural tissue to enter the fourth ventricle, which is positioned between the cerebellum, which is here, and the brainstem, which is here. Okay, and then far lateral approach, which brings you over here. So completely laterally from these approaches to the lateral part of the brainstem. And also many of the cranial nerves can be like this, all of them, so 9, 10, 11, and 12 as well. Okay, and these are just for the review approaches from the backside. So we have anterior approaches and posterior approaches, also lateral approaches, and this is the posterior view, suprainfratentorial, telovelar, and retrosigmoid. So retrosigmoid, which is most commonly used for surgery in the CP angle, where neurovascular complexes of the posterior fossa are placed. I talked about these neurovascular complexes in more details in my previous lecture. Okay. And then an interesting approach from the interior, as I mentioned, the transoral approach. So if you imagine the mouth here, you will see this later, open, it brings you through the clivus, which is right here, over here to the pyramids of the brainstem. So this is the medulla oblongata, and it brings you kind of also to the midline, which is very convenient because you can bypass in this way through these midline approaches this line of cranial nerves, which is positioned here. So if you consider this area, it is completely surrounded with cranial nerves. And when the surgery is usually done from other approaches, from the lateral to the medial. So we have to cross this barrier of cranial nerves. And as you go from the lateral to the medial, the risk of surgery is getting higher and higher because you can injure some of these vital nerves, which are very important, and they are the thing that divides good quality of life from very poor invalid quality of life. So this is also the beauty of neurosurgery, because all these things come into matter here. Okay, and finally the endoscopic endonasal approaches. This is the wide area where they can bring you. You see the complete midline and also much of the cranial nerves. Okay, almost all of them, which can be found in the posterior fossa. Yes, in the infratentorial space. So these approaches are most commonly used today, not transorally, but endonasal approaches. Okay, and all of them put together, these are the anterior approaches. Okay, so the transcavernous approach, then the endoscopic approaches here, retrosigmoid, Cavazzi approach, then this far lateral approach, and also some combined suprainfratentorial presigmoid approach, which is also one of the combined approaches, but this is more complex, and I will focus today on most basic of these approaches. Okay, so now we will have a short review to show you exactly the anatomy. So now I just put you and dragged you around with all these approaches, and now I hope this will all make sense and fit in its place. Okay, so first we will consider the brainstem and cerebellum. So if we consider that we open the skull, we did the craniotomy as we saw it. So you have first the skin incision, opening the wound, then transecting the subcutaneous tissues, and then going to the bone. You perform a craniotomy. Let's say this was a suboccipital craniotomy as you saw it, and this brought us through the squama of the occipital bone over here. So this is the occipital bone to the posterior cranial fossa, and we also transected the C1. This is the posterior arch of the atlas, the first vertebra, cervical vertebra. So it brought us to this area. So we also removed in this cadaveric specimen the cerebellum, So we have the complete brain stem viewed from the back side over here, including the its posterior part, which is the floor of the fourth ventricle, the fossa rhamboidea. Okay. So I will just briefly review all the structure because I talked about this already in my last talk. So this is the vertebral artery, which is going through the transverse processes of the cervical vertebrae. Okay, here. So it courses around here, enters the skull through the foramen magnum, which is positioned here. So this is a large opening on the occipital bone, which makes a communication between the spinal canal, which is positioned in the vertebral column, and the intracranial space, which is positioned inside the head, inside the skull. Okay, so we have vertebral artery coursing through this transverse process, then coursing through the foramen magnum closer to the midline, and then finally going to the anterior part of the brainstem. So we don't see it here because it's in front of this, and forming the circulation of the posterior fossa. I'm talking about this because this is very important, and these relationships of the vascular structures and nervous structures are the most complex relationships in the whole intracranial anatomy, perhaps. Okay, so if we remove the brainstem, we can see further how this artery goes. So it makes the basilar artery here in front of the brainstem. Okay, and this basilar artery gives its last branches here. This is the bifurcation of the basilar artery, which gives the two posterior cerebellar arteries, which are supplying the posterior parts of the cerebrum. Okay, so it is joining with these two arteries the circle of Willis, which is positioned on the base of the brain and gives supply to the to the cerebral hemispheres and to the supratentorial space. But also it gives supply to the complete infratentorial space, which can all the neural structures in the infratentorial space, which we can find here. So I will just briefly review these divisions. So if when it courses from below to above, it first gives the pica, or posterior inferior cerebellar artery. This artery is it has most variable position. So the origin of pica is usually unusual, and it can also arise extradurally. So this can be very important while performing the far lateral approach. I was talking about this in my presentation earlier, because surgeons can sometimes confuse the extradural origin of the pica, which is a large artery which supplies the suboccipital surface of the cerebellum. So if this artery is sacrificed, it can cause infarction of the posterior part of the brainstem, of the suboccipital surface of the cerebellum, which can be devastating. So because of this, the surgeon must be very careful while doing the approaches to this part, because pica can have such variable origin that it can also arise extradurally. This is called the extradural origin of the pica. Then, as we go to the above, we can see the ica here. So pica, ica. Ica is less variable in its origin than pica, but also is. So you can expect ica to be found in this complete intracranial part, lower to the most superior arteries that arise from the basilar artery. Okay, so ica, or anterior inferior cerebellar artery, supplies the petrosal surfaces of the cerebellum. So these are the surfaces that lie here. Okay, so they face the petrosal, the petrous part of the temporal bone. These are the pyramids, so-called here. Okay, so this artery also is very important, and it usually is preserved, but as well. It can cause some problems. As you can see here, it comes into close contact with some nerves, and by that it can cause neuralgias and cause some significant problems with this. And microvascular decompressions operations are usually done to relieve this pressure of nerves. And finally, yes, we have the SCA, or the superior cerebellar artery, which supplies the most superior tentorial surface of the cerebellum, and then the PCAs. These are the posterior cerebral arteries, which are joining the circles of Willis. So vertebral artery, basilar artery, then pica, which can arise either from vertebrals or from the basilar, or even extradurally, then the ICAs here, and then the SCAs here. And finally, ending up with PCAs which join the circle of Willis. Okay, this is a view from the lateral, just to show you the proximity of this. This is the asterion, so junction of the bones here in this posterolateral part of the skull. So the important structures here are these sinuses. This is the transverse sinus and the sigmoid sinus here, which goes down there to the jugular vein, internal jugular vein. Also, this vein can be found under the mastoid, which is very interesting, sigmoid sinus. So we will consider the transmastoid approach just very soon. And in this approach, you can visualize this jugular, this part of the sinus. Then the semicircular canals, which are the vestibule. So if the translabyrinthine approach is done, it can be performed through this, or usually the partial labyrinthectomies are done, which can preserve some of the hearings. But these approaches usually have to sacrifice the hearing. And then the ear, the external acoustic meatus, porous of the external acoustic meatus, and then going to the cochlea, or the internal ear, where the sound of hearing, the organ of hearing is positioned. Okay, and then just the surfaces of the cerebellum. So this is the supratentorial surface. As I mentioned, these are the branches of the SCA that arises from the basilar artery over here. So the SCA courses around the brainstem and then branches over the complete supratentorial surface of the cerebellum. Tentorial surface, not supratentorial. Sorry, and this is another interesting thing. These arteries usually are residing in their fissures. So this is a fissure between the cerebellum and the brainstem above. So this is the cerebellomesencephalic fissure. Okay, and SCA is usually found in this fissure, which can have few trunks, and it can be also very variable in its flow. Then, as we consider this anterior part of the SCA, so as I said, it arises from the basilar artery, and then this is an anomaly. So the SCA, which is consisting of two trunks, and as you see, one of these trunks is very close to these nerves. And this nerve right here is the trigeminal nerve. So this slide is very interesting because it shows you how what is the proposed mechanism for occurrence of the trigeminal neuralgia. So this is the unbearable pain, one of the worst pains that a human being can experience. On a scale from 1 to 10, they usually call it 10. So the pain in the middle part of the face, usually unilateral, and this is usually caused by the gradual down sloping of the SCA in the posterior fossa, where it comes into close contact with the upper surface of the trigeminal nerve, and while pulsating causes causes contact with the nerve, which then transmits signals and causes pain. Okay, so the last talk I did on this theme was just few days after Professor Peter Janetta died, who is one of the greatest neurosurgeons of the last century, who found a way to remove this pain and to operate these patients. So he invented a surgical technique that is called the microvascular decompression surgery, where usually a soft plate of Teflon is positioned right here, so below this course of the SCA, a loop of SCA, and then this Teflon is kind of a cushion that does not allow the pulsations of the artery to hurt the trigeminal nerve and to cause pain in the patient. This can be very variable also, but usually this approach can be done through the retrosigmoid craniotomy and approach as I showed you earlier. So you can have access to the CP angle, and this can be done in this way. So the piece of Teflon is positioned, and this is the microvascular decompression invented by Dr. Peter Janetta in the last century. Okay, and also we must not forget the venous structures. So this is the petrosal surface of the cerebellum, which looks up to the posterior part of the petrous bone, which is part of the temporal bone. Okay, so from the lateral, this is anterolateral part of the brainstem, cerebellum, and this anterolateral surface of the cerebellum is called the petrous surface. Okay, which watches at this bone, which is called the petrous bone. And we have here the sinuses of the posterior fossa around it. And finally, some of the large views. So this is the complete view in front. I also talked about many of these structures, but this is the pons, or the middle part of the brainstem. This is the inferior part of the brainstem with pyramids, olives, which are lateral. These structures are important because they resemble some very important pathways, neurological pathways, but also are, in surgical terms, the places that explain the origins of the cranial nerves. And also the important cranial nerves of the posterior fossa, so the trigeminal nerve, 7, 8, 9, 10, 11, and 12, notice of 12 here, which all go here to the internal acoustic porous meatus and then through the internal ear. Okay, and also the foramen of Luschka, which is positioned here. This foramen of Luschka I talked about more in my previous lecture, but it is a communication between the anterior part of the so the CP angle, which is the anterolateral part of the brainstem, and the posterior part of the brainstem, or the fourth ventricle, which is positioned between the cerebellum and the brainstem. Okay, so this is the foramen of Luschka, one of the openings of the main cavity of the fourth ventricle. Okay, so this is just the close-up view of this foramen of Luschka, which is positioned here. When you see this structure, which is very interesting in its appearance, this is the choroid plexus of the fourth ventricle. So this is the structure that produces the cerebrospinal fluid. It's thought to be produced here, and it covers or it arises from the foramen of Luschka, which leads you to the cavity of the fourth ventricle. Okay, and again, all these structures that are viewed here, as I said, this can be approached through the combined suprainfratentorial presigmoid approach, which is the approach that is going through this upper part of the CP angle and allows you to see all these structures, okay? So 7 and 8, this is ICA, this is the SCA here, looping around, and this is probably the vertebral artery coursing around here and joining into the basilar artery, and pica coursing around here. Okay, so this is the medulla, the petrosal surface of the cerebellum, flocculus, one of the most primitive nodes, lobules of the cerebellum, and the choroid plexus with the foramen flushka. Okay, and finally, the complete view, you can see all the things that I was talking about. So all these things put together form a very interesting and easy way to remember all these structures, and these are the neurovascular complexes. These complexes were greatly explained in the great book of Professor Rotten, to which this whole set of lectures is in honor of him. It was made, so Professor Rotten's book, which is, as was mentioned, the bestseller, neurosurgical bestseller of all times, Rotten Cranial Anatomy and Surgical Approaches. So in this book, he was giving the concept of 3 neurovascular complexes, the lower, middle, and upper, which are consisting of one of the 3 arteries that I was talking about. So the pica, which consists the lower neurovascular complex, ICA, which is comprising the middle neurovascular complex, and then the SCA, which is comprising the upper neurovascular complex. Okay, so if you imagine just that you have 3 arteries and all the structures that they pass around over here are making the neurovascular complex of each of these arteries. Okay, so this simplifies this concept much more, and I talked about this in my previous lecture. Okay, and finally some other views. This is important because now we will just consider this part of the anatomy. So 7th and 8th nerve, which are going above the flocculus and coming laterally to this, as I mentioned, the posterior part of the vitreous bone, and finally to the internal acoustic meatus, which is this. So we have the 7th nerve or facial nerve, then the 8th nerve or the vestibulocochlear nerve, and this interesting structure here. This is, of course, the nervus intermedius. So the intermediate nerve also courses inside the internal acoustic meatus, and it can sometimes consist of as much as 16 bundles. So it can be very complicated in its appearance, and all these nerves are usually bound together in the arachnoid. So this is very important. And Professor Rotten advocated that approaches to this part of if you are drilling into this part of the temporal bone, you should always try to think in this way, because as you can see here, you have more space around here than here. Okay, so it is usually better to approach this region from medial, if it can be done, than from lateral, because this space is gradually becoming tighter and tighter, and most tight to the inner part of the meatus, so the fundus of the meatus, which is the bottom of this tube, bony tube here, and you can usually tell this fundus by this structure over here. I will close it up in a second, but this is the Bill's bar, which was made after Bill House, who was an ENT surgeon who was doing much of the thinking about the approaches to this area. So this is kind of one of the areas where ENT surgery and neurosurgery have most common interests, and usually these approaches are done in a combination I mean with consultations between neurosurgeons and ENT surgeons. And finally, close up on the Bill's bar and the fundus of the meatus. So the porous, meatus, and fundus. Bill's bar, upper part, inferior part. Okay. So facial nerve enters its areas. We have superior facial area and inferior, and also the areas in which the other nerves go. So this is the slide. To show this better, I have a slide right after this one, and this slide wants to show you the structure that I haven't shown already, and this is the view of that bone that I was talking about. So this is the posterior part of the petrous bone, okay, and these are the nerves arising here from the brainstem: trigeminal nerve, facial nerve, vestibulocochlear, jugular bulb over here, and then the endolymphatic sac, which is positioned here under the dura of the posterior bone. So we have the occipital bone, temporal bone, and the apex of the temporal bone. So if we think now, the Cavazzi approach or anterior petrosectomy is usually done here. Okay, so under the trigeminal nerve and in this part of the bone, taking care to preserve hearing and cochlea, which is positioned right here. Okay. And finally, as we are closing up, approaching, and that's I think this area, we can also see, as I mentioned, the jugular bulb and the carotid artery, which is coursing here in the anterior part of this petrous bone. Finally, the slide I wanted to show you. Okay, so this is the fundus of the meatus, and this is the Bill's bar, making it into two halves. So this is the facial area in which the facial nerve enters. So this is the superior vestibular area in which one of the vestibular nerves goes. Okay, so we have the seventh nerve, which is the facial nerve. It goes through this foramen. Then the vestibulocochlear nerve, which is combined of two nerves. So this is the vestibular nerve and cochlear nerve. So vestibular nerve goes over here, one segment of it, so upper segment, then the lower segment, and then finally the cochlear nerve, which is going through this very interesting tractus spiralis foraminosus. This is the spiral tract which gives access of this nerve, little nerves, to the cochlea and innervates it. Okay, and now up to the approaches. So T-lobular approach brings us to the fourth ventricle. So now we can see the suboccipital surface of the cerebellum. These are the tonsils, the vermis, and the hemispheres of the cerebellum. This is also the tila choroidea of the fourth ventricle. So these are the envelopes which are surrounding the open parts of the fourth ventricle, allowing it to become a cavity. Okay, and finally the foramen of Magenda, which is positioned below here. And when we are trying to do a T-lobular approach, usually a spatula, after you do the suboccipital craniotomy, the spatula is placed here on the tonsil, and the tonsils can be retracted. This area is like this, and this gives you access to this very thin membrane here, which is comprised of the velum medullary inferior. So this is the inferior medullary velum, and the tila choroidea, which is so thin that it is transparent over here. And you can transect this without hurting the neural tissue and enter the fourth ventricle. Okay, and this is the anatomical view of the fourth ventricle. I talked about all of this in my previous talks, but just to bind it up together, I will just mention that you have one sulcus here, which is the median sulcus, then two lateral sulcus, which are the limited sulci, which are dividing this middle part in lateral parts. This is the transfer process of this cavity, which ends up here with the foramen of Luschka on both sides. This is the foramen of Magenda here. And in the middle part, you have these two identical structures. These are the median eminences. Okay, so median eminences, which are surrounding this median sulcus. These are actually the cranial nuclei of the cranial nerves stacked up one upon the other. And then lateral to these are the vestibular areas with vestibular nuclei. So there are four of them, and they have this rhomboid shape.
Well, now may be a good time to end this presentation. We'd like to thank Slaven. I hope he can come back on. And thank you for the guests for coming. And let's have some comments. First from Rakesh.
Hello. Hello, Dr. John, and hi, Dr. Simon. It was an excellent presentation by Slaven. I'm really amazed to see his knowledge in the neuroanatomy, which is a very basic for any neurosurgeon, and it is very important for every neurosurgeon. And the way he has he's trying to master, and the way he has mastered a few slides in roton collection is awesome. And during this presentation, he was also correlating with the clinical conditions like trigeminal neuralgia, the superior cerebellar artery compressing the trigeminal nerve, and that producing the symptoms, and how we keep a Teflon, and showing the roton collection. That was awesome. It's a really great presentation. I think we should go on with these presentations, the neuroanatomy, which forms the basis of neurosurgery. So we should have a series of these roton collection lectures. This was a great presentation. Thank you.
Yeah, that would be a great idea. And Simon?
Yes, thank you. Yeah, it was an excellent presentation. My question is, when a neurosurgeon travels from one country to another, perhaps to perform a surgery, would he be then performing the surgery in exactly the same way that he did in his own country because of the procedure that is accepted worldwide, or would there be some changes? Perhaps Rakesh can answer that.
Yeah, that was a nice question. Perhaps there are certain standard guidelines which have been proposed to avoid this confusion. So nowadays, the medicine and surgery is all about standard guidelines. So there is a standard procedure which is accepted by worldwide surgeons, neurosurgeons. So that is the standard procedures performed in 99% of the times. So unless there is a institutional protocol that you have to change, otherwise most of the times it is a standard approach that is followed worldwide, and that has to be approached.
I see. Thank you. But there might be some differences. They're talking about there's slight differences.
No, for a given disease, for a given tumor or a given lesion in the brain, there is a given standard approach worldwide which is accepted. Unless there is an institutional protocol, this is being followed most of the times. Okay.
Thank you.
You know, one comment I'd like to make, you know, he gave a presentation like a seasoned neurosurgeon at a conference, and he really, I think, utilized this platform of Hangout very well. The way he was pointing out with the pointer on the screen, it was just like being at a conference.
Yes.
You know, one comment I'd like to make, and Rakesh, maybe you might be able to answer this, is that, and the more I get involved, and maybe Simon will agree, with the neurosurgical community, the more I see that anatomy is such a vital part of being a neurosurgeon. They really have to know the anatomy and the anomalies very, very well. Can you comment on that, Rakesh?
Yeah. As far as anatomy is concerned, is very important for any surgeon. And when it comes to this part of the body, that is brain, neuroanatomy, that is anatomy, forms a very, very important and very, very basic and must master part of the surgery, because any other part of the body, there is a room for you to meddle around, but here the room is very, very restricted, and you have to be very, very precise, and you should know exactly where your structures come. So neuroanatomy is very important for each of a neurosurgeon, because if you miss a precision, you are going to give a patient a lifelong deficit. So neuroanatomy forms a very, very basic and very, very important thing in neurosurgery.
When you were in medical school, Rakesh, did you realize that you want to be a neurosurgeon after you took anatomy?
I didn't make up when I was studying anatomy, but as I went through my medical second year and third year of my medical course, and one of the times when I heard a neurosurgeon speaking, so was I was amazed by the precision and exactness that it requires. So that is when I decided I should become a neurosurgeon. So uh,
Very good.
yeah,
Well, soon, Rakesh, you will be giving presentations. Well, I'd
I
like to
hope so.
thank
I'm
you.
a
I
Slavic.
look, I look forward to that day, and I think Slaven is showing us how it can be done in a Hangout platform. Any parting comments, Simon?
No, thank you. Just that I look forward to seeing more, and the more I see, the more I learn. Compared to the first time I looked at the Rotom collection, and now it's so much different. And comparing what I learned in medical school to this, it's night and day. I mean, sure, I learned things, but not in this much detail. So it's a wonderful experience.
Yeah, I think that was a good idea of Rakesh to have Slaven do a Roton series. He certainly has
Mm,
great material to work with.
yes,
So we'll
yes.
wrap this up, and thank you, gentlemen, for coming, and we'll continue on with more presentations in the neurotrauma series. Thank you very much.
Thank you.